Alrighty, so again, it's okay if you don't want to sit down, but if you could just get a little quieter. I'm going to tell you a little bit about our next speaker. Thanks, shushers. Good teamwork. Okay, so now I have the pleasure of introducing Maxi Miciak. Yeah. So Maxi works centers on informing clinical practice and healthcare system decisions to strengthen patient-centered care. Her research focuses on developing, implementing, and evaluating care models and practices that impact patient-practitioner therapeutic relationship, including how health services and policy support this relationship. Most notably, she's developed a pragmatic framework on the therapeutic relationship in physiotherapy to support physiotherapists in making meaningful action when developing positive relationships with their patients. Her appreciation for the therapeutic relationship developed over 13 years as a physiotherapist working in private practice and on interdisciplinary rehabilitation teams, supporting people with a diverse range of musculoskeletal conditions, chronic pain conditions, mild traumatic brain injury, and psychological dysregulation, such as depression or post-traumatic stress. Currently, Maxi is also working on with multiple stakeholders across Canada to bridge the research-to-practice policy gap by co-developing and co-implementing a framework that assesses research, impact on decision-making, and policy and practice, dovetailing with her interest in assessing the scale and spread of research and innovation in the healthcare system. Maxi received her Bachelor of Physical Education, specializing in athletic therapy, with honors in 1992, and a Bachelor's of Science in Physical Therapy, also with honors, in 1996, both degrees from University of Alberta, Edmonton, Canada. In 2015, she completed her doctoral studies in rehabilitation science at the University of Alberta. She is currently a postdoctoral fellow at Alberta Innovates and the University of Alberta, serving as the inaugural Cy Frank Fellow in Impact Assessment.
That was a bit too long, I think. I didn't realize that whole thing was going to be read. Note to self. And I'm certainly not going to be here talking about policy and research impact. We can have fire talks and taco talks about that. I'm here today to talk to you about the therapeutic relationship, and something obviously I'm very passionate about. Continue to research, and really I want to talk today about how being, or how we are in relationship, informs the quality of what we do in relationship. And really how that creates a safe container for relationships with our patients. And I'd like to thank Rajam for asking me to be here, because I think it was last February when she texted me, DM'd me right after the pain summit last year and said, hey, would you like to present? And I thought to myself, okay, it took me about 5 seconds to answer. Part of that is because this is what it looks like in February in Edmonton, Alberta, Canada, where I am from. This is what it looks like in San Diego in February. Check, right? I love Mexican food. Now, I have a hypothesis that the closer you are to Mexico, the better the Mexican food is going to be. I am 1,900 miles away from Mexico in Edmonton, Alberta, Canada. I am a short drive to Mexico from San Diego. And I had the best fish tacos I've ever had in my life last night. So check. There we go. But really why I'm here is for inspiring conversations and connections with you all. This image is of a tweet that a Twitter buddy of mine, Georgie, tweeted to me, and I found it in my Twitter inbox one Sunday morning, and as I was having coffee. I think it was in the springtime last year, and we'd been having a Twitter conversation about the conditions of engagement, and this is what I woke up to this Sunday morning. She says, I've been watching these flowers. It would seem that they only open their petals when conditions are right for them. Bit like humans, hey? Do we spend enough time working out what conditions people need to open up and be receptive to change? So, I mean, granted, I was stunned, hadn't had a coffee yet Sunday morning. However, this tweet just hit me, it stunned me, because here I'd been studying the therapeutic relationship for a few years. I've been thinking about it for even more than a few years and trying to practice it. And somebody noticed something in their environment that was so beautiful and poignant that took my understanding of it to a deeper level. And so those are the kinds of conversations that I'm hoping. I mean, I get to stand up here and talk for 45 minutes, but really this is about a conversation that I think we should be having in our professions as physical therapists, but across professions, across our disciplines. So, that said, the plan is I'm going to mash up background, review the conditions of engagement, and talk about how to create a safe container. I'm going to mash that all up, and I'm going to pitch it to you. And hopefully what's going to happen is that you're going to be able to recognize the conditions better because you'll have a bit of a framework to see them through. Maybe pick out a couple ways that you can manifest the conditions, and once again, inspire some conversations. And I just want to say that I'm going to be pulling together my research on the therapeutic relationship, my clinical experience. Also, I have psychotherapy training in trauma and in a body-centered and mindfulness-centered form of psychotherapy called Hakomi. So I'm pulling that training in, and also some psychotherapy theory, all right? So let's talk about research and the therapeutic relationship. So within rehabilitation, and so my lens is rehabilitation, there hasn't been a ton of research regarding the therapeutic relationship compared to other disciplines, for example, like psychotherapy, where it's been going on for decades, and they have meta-analysis upon meta-analysis that say that the therapeutic relationship has just as much influence on clinical outcomes as do any treatment intervention that's applied in practice, right? But it's growing, and there seems to be a momentum around it. Now, what we do know is that apparently relational elements like listening, empathy, nonverbal behaviors are apparently important to clinicians and patients. And they're so important that there seems to be a relationship between good therapeutic relationships or alliances and satisfaction, patient satisfaction, and maybe even on follow-through with patients and what you've constructed as a treatment plan. And there's also, apparently, some relationship with clinical outcomes, including pain, function, and mood. But all of these studies all ask for more and better research, as you do when you're a researcher. There always needs to be more, and there always needs to be better. But in this case, I truly believe so when I was a clinician, as was introduced, I worked in the workers' compensation system. I worked a lot with people with persistent pain, who were managing persistent pain, living with persistent pain, but also people with psychological conditions, psychological dysregulation. And I started doing a psychotherapy training in order to help me develop better relationships with my patients, because I recognized how important that was with the people that I was working with. But what I recognized was that there wasn't this kind of information in physiotherapy. I had to go outside of my own discipline to get training and knowledge in doing this. And so, like you do, I gave up a really well-paying job and pension and went back and did a PhD. And my goal was to develop a conceptual framework of the therapeutic relationship in physiotherapy. And I used, because there was not a lot of research in this area, we hadn't plumbed down into the depths of it, I had to use qualitative methodology. So I used a method called interpretive description. Now, interpretive description, for any researchy kind of people out there, is a qualitative method that likes to stick close to clinical practice. So we don't get too theoretical. We like to make sure that clinicians can recognize the findings and that maybe they can even be applied in practice. And I did this study in private practices in Edmonton, Alberta, Canada, interviewing patients and therapists, and then broke my brain doing a qualitative content analysis. And what I did come up with was a framework of the therapeutic relationship. It has 3 components. As you can see, at noon o'clock is establishing connections. So one of the components is ways of establishing connections. At 3 o'clock is the bond, or that positive affective resonance between 2 people or between patient and therapist. And what we're going to be talking about today at 9 o'clock are the conditions of engagement. Excuse me, I've got a bit of, Antonio and I have a lot in common. I have a bit of a cold. So I want to go through some key assumptions before I go further. The first assumption that we're going to operate under is that human relationships are complex, meaning there are no algorithms with human relationships. There are no ticky boxes with human relationships. They are emergent, and we need to be responsive, and we need to be nimble. Both clinician and patient need to engage in the relationship. However, clinicians are responsible for setting the conditions of engagement. And breakdowns in relationship happen when the clinician or patient or both, for whatever reason, can't engage. And that could be in the moment, or that could be, over time. So I'm going to present and weave in a case as well into the presentation. And Lana is a person that I was working with more in my private practice. And Lana's social picture was that when I was seeing her, she was 37 years old, and she and her husband had an 8-year-old daughter. She had an excellent relationship with her daughter, and this relationship was a huge resource for her emotionally. And she also really enjoyed teaching kids piano, so another resource. However, there were a lot of stresses in Lana's life. She also foster parented 2 very high needs children. There's significant marital stress in her life, partly because of the child rearing, but also for other reasons, as you might intuit a little bit later. She also worked at a really high-stress job. She had a lot of responsibility with this job, and she was very sedentary. And she disclosed to me that she had a very self-reliant personality, or a personality where she had difficulty asking for help and or receiving help. And so this led to poor boundaries around work and her relationships. So she came to me with a diagnosis of persistent neck and back pain. No particular mechanism of injury. She'd never hurt herself, never been in a car accident, just had come on. However, she also had a diagnosis of post-traumatic stress disorder from child abuse, significant sexual abuse as a child. And this also came with panic attacks and depression. She was seeing a psychologist at the time I was seeing her, and the psychologist actually referred her to me because we had taken some psychotherapy training together, and he knew that I would be able to work with him to address some specific challenges that she was having with her pain. She also had seen chiropractor and massage, but they hadn't helped. And actually, her pain had increased after she'd gone for these treatments. And she also disclosed to me, this is unsolicited, I don't normally ask people, so how's your relationship with your doctor? She disclosed to me that she had poor therapeutic relationships with her physician and her orthodontist. She didn't feel like she was being heard with them. And so that is a nice segue into talking about safety, because Lana really didn't feel safe with her physician or her orthodontist. And so I want to break up safety into 2 categories, and they are not mutually exclusive categories. By any means, they're very related. And I'm sure Antonio Damasio, if he was here, if you've read Descartes' Error, you will recognize that as well. But for simplicity's sake, we're going to go with two categories. So the first category is implicit safety. And so essentially, implicit safety is that sense of feeling at ease, okay, or falling into a sense of feeling at ease. And it's hardwired, all right? We have this based on an evolutionary process or evolutionary development within our nervous system that leads to a neuroception, so our ability to sense outside of ourselves without conscious awareness or conscious activation, okay? So this is brought on by, the sense of safety is brought on by nonverbal cues, right, that indicate life, threat, danger, or safety, all right? And when we have a sense of safety activated in our nervous system, our social engagement system is activated, all right? Now, explicit safety comes through more social development, all right? It's the learnings that we have as we grow up developmentally, and we develop certain beliefs about ourselves and beliefs about the world, all right? But essentially, what we want in this world, what everybody wants, is we want to be seen, acknowledged, we want to be able to express ourselves, and we want to be accepted, all right? And this is built through attending to small acknowledgments, okay? It doesn't have to be a big monumentous gesture, but Brene Brown talks about the small acknowledgments that you make with people from a day-to-day basis that begin to build that sense of trust and safety. So that leads us into talking about, well, what are those conditions of safety? What are the conditions that we need to engage in a safe way with our patient? Well, from my research, the definition that came out of that was the conditions of engagement are the intentions and the attitudes that ground us and facilitate investment in a relationship. So basically, in a nutshell, it's the way you approach the interactions you have with your patients. It's how you enter into every single interaction you have with your patient, all right? The intentions and attitudes that you take in. And those conditions, the 4 conditions we're going to go through today, form the structure of a safe container, all right? So while I get another drink of water, I'm going to let you digest the safe container, literally a container. I'm not that creative. So the 4 conditions are placed around this box, this container, and they're placed very strategically. So on the bottom of the box is present, being present, all right? Every container needs a bottom. If you do not have a bottom, you don't have a very successful container. Meaning that presence is absolutely essential as a condition of engagement. And essentially, it's being in the here and now, all right? And being occupied and embodied in the moment that you're in. Being receptive forms the walls of the container. Walls, another very important part of a container. If you don't have walls of some sort, you don't have a container. You can't contain anything. Now, being receptive is about being open, and it's about really being attentive to cues in your environment, all right? Now, being committed and being genuine form the lids. And as you can see, the lids are a bit more mobile, all right? The lids are mobile because they are contingent on personal factors, situational factors, maybe cultural factors. So there's a bit more mobility with the lids, okay? But ultimately, all of these 4 conditions come into play when we're creating a safe container for our patients and ourselves. So let's start with being present. So presence, by definition, from my doctoral work, is an individual's intent and ability to be and remain in the moment, in the here and now of the therapeutic relationship. In other words, it's being immersed in the moment, not thinking about doing anything else. And it also comes with a sense of calm, a physiological sense of calm, and possibly even a psychological sense of calm. But we'll just stick with more of a sense of calm, a physiological sense of calm. So why be present? Well, we want to be present. We're going to go back to that implicit sense of safety. We want to be present because when we are present, it activates that neurobiological system that allows us to be non-threatening to patients. And that elicits in patients a sense of safety. So, as I said before, patients are we are all constantly assessing whether we're safe, whether we're in danger, or whether there's a life threat. Always, right now. So when any of those cues come up, we will activate within our autonomic nervous system, as Antonio Damasio was talking about, but not related to safety, related to emotion, but certain neurological processes start going. We either go into sympathetic response, right, fight or flight, right, very active, mobile, right, a state. We may go into, if it's life threat, a dive response or a dorsal vagal response, where we actually we might feign death, right? Animals feign death in the wild. We might faint. Or it's also talked about in terms of being a contributor to a dissociative state. So we leave, we vacate, if we feel our life is in danger. So when we're with patients, what evokes a sense of safety, or what evokes a social engagement response, are non-threatening, non-verbal social behaviors. Because our bodies, our nervous systems, are scanning for that automatically, all right? And that helps down-regulate sympathetic response, and also that dorsal vagal freeze response. And it opens up connection. It promotes connection with others and engagement with the environment, all right? So this work, you can see the references down at the bottom. Basically, this work is pulling from Stephen Porges' work called the Polyvagal Theory, all right? So I provided a number of references at the end, and we can talk more about if you want to know more about the Polyvagal Theory, because it certainly is one of the key theories that I use when I was working with patients who were, chronic pain patients, persistent pain, but also with trauma as well. So how do you be present? Well, you have to find ways of landing in the moment, all right? We all know we have a lot of different tensions. We have the tensions maybe with the patient that we're with. We have tensions in our social environment at work, and we also have different things going on in our personal lives. All of that, we know through different processes, can influence our state of being at any time. And so we have to find ways to actively land with every patient that we're with, and that can require some preparation, okay? Because ultimately what we need to be able to do is we need to be able to regulate our own nervous systems, all right? If our nervous system is regulated, and I had it on a slide about 3 slides up, and I moved it, and I shouldn't have moved it, but I did. Talking about co-regulation, all right? So if we are grounded, if our nervous systems are regulated, that promotes regulation with the people that we're with, or in this case, the patient that we're with, all right? So it's really important, actually, that we go in calm, right? And landed. Parking out distractions, all right? Blocking out different things, different thoughts, all right? And we can do this by developing rituals or practices. So different ways of regulating yourself are literally breathing, right? Long exhales before you go in to see your next patient. Finding spaces in your body where you actually feel calm or grounded and accessing those spaces. Okay? Key words, key phrases, a talisman, whatever you resonate with. It's very individual. But whatever helps regulate your nervous system, and by regulate your nervous system, I mean your heart rate reduces, your respiration rate calms down, you feel more settled in yourself. You might feel safe, right? So it's really important to have a sense of what that feels like for you and what you need to do to be able to get to that state. But it also requires resetting, because as we know, you can be in an interaction with a patient. They may say something to you that triggers you, and you can dysregulate, all right? And because this is unconscious, this is subconscious, patients pick up on that. Other people pick up on that, and they become dysregulated. So you may need to become, we do need to become aware of in session when we're with patients when we become dysregulated by what's happening, right? So we need to know what our own junk is, right? So that we can reset, okay? So this is a great example, and not because it's my example, because one of the participants in my study talked about this, and it was patients that talked about this. And they talked about the difference between being rushed and being busy. So patients respect that therapists are busy. They know that you are, you're seeing multiple patients in a day. They get that. And quite frankly, they're in awe of it, right? However, they noticed when therapists were rushed. It was a change in the way the therapist was being. And that rubbed them, right? And this patient speaks to it, I think, really beautifully in terms of how his therapists had that ability to reset when they were with him. So he said, they were busy as can be, just on a cycle, going from one to the next and coming back. But they always took the time to make you feel like you were a decent person. Every time I read that, I get a little verklempt because I think, a decent person, wow, that's like, And this, I just want to say, without disclosing who this patient was a high-ranking academic administrator, highly successful, published person, right? Somebody who you would think, well, you must feel safe all the time with people. Not so much, all right? So we need to watch our assumptions as well. So, how do we be present? How do we cultivate that sense? Well, we can use our own bodies to be present, right? And that ties back into the nonverbal social cues, all right? So when we're being present with a patient, when we're trying to influence and co-regulate, there are definitively things that we can do that actually have been studied, all right, that help regulate another person's nervous system. The quality of the eye contact that you make. So soft eye contact versus bug-eyed, right? That's a drastic example, but you get my drift, right? The facial expressions, all right, that we make, all right? The tone of our voice, the prosody, the pace, and the tone of it. Imagine feeling rushed and how your voice changes when you're feeling rushed versus if you're grounded and you've exhaled, what happens? I had to exhale when I came up here. Laughing helps me exhale, so I try and make everybody laugh so we can all exhale, right? Also adjusting proximity, okay? So how close you are to your patient. People who have been through trauma, especially physical trauma, that have breaches in boundaries, all right? They're very sensitive to proximity. They can be very sensitive to proximity. And so watching how close you are, what is your patient like? Do they have their arms crossed? Are their legs crossed? Have they pulled back when you get closer to them or when you move to touch them, right? So adjusting proximity is important. Entrainment, okay? So basically entrainment means mimicking, all right? Mimicking another person. Now, it's been shown in studies that we actually kind of do this naturally, right? When we're with people for a little while, we start to do things. And I mimic people all the time, and it gets me into trouble. But we can do this purposefully as well. So, for example, you're with a patient, and that patient maybe is a bit down that day, and they're sitting in and they're slouched. So you coming in as a physio or another practitioner, sorry, I'm physio lens here. You're coming in as another practitioner, and you're like, oh, we're going to, you're big and you're bold and whatnot, and this person's sitting here like this. You can actually be perceived as a threat to that person, all right? So trying to match your patient, whether it's posture or mood, that can be helpful. And then what you can also do is once you've matched them, then you can start shifting your posture and watch how your patient shift, all right? So we're talking about co-regulation again, all right, and how we can influence another with our nervous systems, okay? Pacing is the same thing. How quickly you're moving, how quickly the session is going, right? It can really be overwhelming for people who aren't ready for a lot of enthusiasm and hyperness. I had to tone myself down a lot. But the key is you really need to be curious and observe and respond. So I think in the improv session yesterday, and again, this isn't about ticky boxes. I will make soft eye contact. I will have a positive facial expression, right? It's not about that. It's about really conscious and congruent interpersonal acts, all right? So that requires you to be present. And it's also going to require you to be receptive. That's the next thing. So sense of being safety can definitely be observed for those of you who are wondering, well, how the hell am I going to know if somebody's feeling safe with me or not, right? Well, this therapist in my study actually said it very eloquently. She said there's an absolute shift in their body. It's something I see in their body reaction. Maybe it's a change in breath, but there's a shift, almost like a bit of a relaxation that they're willing to be there. So if you are attuned with your patient, you'll start to get a sense. And you'll also see it too. You'll see that their arms are no longer here, they're here. They may have sat up and are more engaged, right? They may be leaning forward. The tone of their voice may have changed, right? So those are all ways that you can start to get a sense that your patient is landing with you, all right? So as I said earlier, we need to be aware. And of course, we're very good as practitioners at analyzing our patients, right? Observing our patients, trying to make meaning for our patients and what our patients, why are they doing the things that they're doing? So we like to analyze their baggage quite a bit, and I'm not so sure that we like to analyze our baggage as much, all right? So we need to be reflexive and reflective because, as I said, when we get triggered, that causes a physiological response in our body that actually severs connection, okay? So, I won't preach to you, I will tell you, I have baggage. Now, I'm gonna say what I was good at first, okay? Because I, don't want to beat myself up. So with Lana, I was good at remaining open to, what was presented at each session. I was quite good at tracking her body and adjusting treatment, right, with her input. And I was really good at identifying and building resources with her, okay? Now, what was a stumbling block for me was that I was afraid that I was going to hurt her. So, I think we all have that sense with our patients. We don't want to hurt them. We don't want to harm them. Yes, it's true, right? But Lana's nervous system was so hypervigilant that I didn't want to have her leave, be triggered, be in a lot of pain, and then, here's the kicker, have her blame me for it. So there's a lot rolled up into that, right? So I didn't trust her to set boundaries. Not always, I did trust her, we worked together, right? But there'd be times when I wouldn't quite trust her to set a boundary, and so I'd be overcautious, and I would take care of her, right? I'd get anxious, and so you can imagine if I'm getting anxious, well, she's probably picking it up and getting anxious too, right? And it affected my ability to collaborate with her, right? If I didn't trust her and I was taking care of her, I wasn't engaging her any longer. I was dictating what was happening, all right? So that's kind of, and this was on reflection and, margarita talk at the fire pit, right? But actually a conversation that she and I had and that she pointed this out to me. So, we're done with presence. Now we're at receptive. So being receptive is about being open and being attentive, okay? So from the study that I did, there are two sort of categories or brands of receptivity, all right? Focused receptivity, where we are attuning to our patient and really observing them, all right? For their state, their needs, their wants, their nonverbal communication, and we're picking up on that. Then there's an open attitude, right? So that's about suspending judgment, okay? And that willingness or that intention of working together, okay? And you can imagine that open attitudes fluctuate, maybe within a session or from session to session, right? So it's not as simple as, we want to make believe it is. So when we're talking about manifesting, manifesting receptivity, right? That focused receptivity. Ways that I learned to do it within my training was through tracking and making contact. So tracking is that gentle observation. You're not freaking somebody out, right? Like you're glaring at them, but you're observing them, their wholeness, okay? You're watching and you're listening very closely, all right? And then you're gonna just touch upon or make contact, verbally or non-verbally, with things that you've perceived, okay? So, things that we track, right? Well, we track the body, right? When I was doing my psychotherapy training, I was like the only physiotherapist among, I think there was a body worker, myself, and then the rest of the class were mental health workers, psychologists, social workers, you know. So actually I noticed that I was probably more attuned to the body than they were, right? So that's where I would always go. I would track the body, right? So postures, tensions, twitches, anything. You're just watching, you're picking it up. Their speech. Feelings. I think I have the definition of feelings correct, right, Antonio, if you're out there? Feelings, right? So you're actually trying to track, are they sad, are they happy, are they frustrated, are they angry, right? Comments from their story, all right? People, places, circumstances, situations. You're listening, all right? Listening without the intention to interject. And also resources, so you really want to hear their strengths and their resilience, okay? So examples of contacting now. So you're observing something, a verbal contact statement would be, for example, it sounds like you're afraid to hurt yourself. Right? That's frustrating, huh? Your shoulders tighten talking about the accident. They may not realize that, but you're going to point it out to them. And it's showing that you're seeing them. You're doing that movement really well. Resource, simple. Your breath seems more relaxed. So it's really, honestly, contacting the obvious. So if you're paying attention, if you're present, right, and you're receptive, you can find very simple things to contact. And the short and simple can be a lot better, all right? You're not trying to psychoanalyze people. You're not trying to plumb to the depths of meaning with them. Really, you're just being with them and acknowledging them for what they're bringing to the table at the moment. Using a curious tone. So it's not about being definitive or figuring it out, like, oh, that's what it is, that you are frustrated. It's more about a question, because a question, a curious tone, opens up space for them to enter and to correct you. Wouldn't that be great if a patient thought that they could maybe refine or correct what their healthcare provider was putting forth to them, all right? And reframing. So what is this patient really telling me? So I think that anybody who's worked with people who experience persistent pain probably have come across people or moments with patients where, you know, on a visual analog scale, they've said they're a 12 out of 10. And I know that certainly as a younger therapist, it took everything in me to not say, you can't be a 12 out of 10. Right? I asked you, so what are you out of 10, right? And I think as I, matured, but also just, being more attuned to relationship, it was more about, what are they trying to tell me? Oh, you're having a really shitty day. Oh, something happened. What's going on? Wow, can you tell me more about that, right? So it's about opening up conversation with that person, all right? So I'm just going to quickly go over this. I've mentioned resource a few times, and I know probably many of you know what I'm talking about, but just so that we're clear, a resource is an indicator of strength or resilience, and I'm bringing it up because I don't think that we build resource, we help bring resource to the surface with our patients enough, all right? And I really think it's important because when we track and contact resources, it demonstrates that we see and value that person, right? It helps build that patient's confidence because it reminds them of their strength, right? It reminds them of the things that they're doing well. And sometimes you can even flip something that would seem to not be a resource. Actually, you can pretty well flip anything that would seem not to be a resource to a resource, all right? So Lana's self-reliance, I indicated in her history as probably not a resource, probably something that was limiting her. But actually, I was able to reframe it also on the flip side, because in certain situations, it's a huge resource to be self-reliant, right? It's a huge positive. So contacting it, saying, people can depend on you. Like, you're really dependable, you know? You really take pride in what you do. That's a resource, right? Acknowledging that part of her, because being self-reliant is a part of herself. So it's not about shaming people, it's about helping them see both sides of it. So, being open now. So if we're making room for the story, so we're still in receptive, still in receptivity. We've moved away from focused receptivity. Now we're being open, all right? So really, I think the key to this is making room for the story. And I know that everybody's heard this. The story and narratives are in our consciousness right now. It's really something that is being promoted. But really, the story gets at more than just the physical with people, all right? It brings out body and emotional responses, all right, that you can track, okay? It brings out their needs, and it uncovers resources, all right? So if we actually give people the space to just speak, they aren't going to take the full, likely going to take the full time. I didn't recently read this study. Where was it? Can't remember. Maybe last year I read it. These researchers in Germany, I believe, did a study with physicians. And they actually videotaped sessions, consultation sessions, and the physicians were just to let the patients speak and not interrupt them. And what they found was, on average, patients spoke nonstop for about 2 minutes. And then they looked at the physician as if to say, and, like, you know, so they were waiting for the physician then to speak. So that's in medicine. It may be different in other, countries in the world, maybe different in other professions. But it's just to say, don't get too worked up about, opening up space for a story in terms of time. So, how do we make room? Well, again, it's about intention, right? It's about an attitude. It's about the sense of curiosity, okay? An inviting story. So phrases like, paint me a picture of what you mean. How does that seem to you? What is important? What is important to you? That seems important. Can you speak more to that? Right? Allowing them to come in, okay? And give space, don't fill it, as I was saying. But I was speaking with a colleague, I think it was a couple weeks ago, and she turned me on to a new strategy, and it's the wait for 8 strategy. So literally, you ask a question, and you wait for 8 seconds. And even after the person stops speaking, you can then wait another 8 seconds before you interject to see if there's anything else that wants to come out. And she said it's the most excruciating thing to wait for 8 seconds. 8 freaking seconds, that's not long, but it's long, right? So there's a little nugget for you. Try, if you take anything out of this, wait for 8 and see what happens, right? Oh, did I finish that? Oh, don't discount the story. So suspending judgment, okay? There are lots of times when we get triggered, and for example, somebody may come in and say, my pain is increased, and I think this is what happened, right? And in our minds, we're going, that is not possible, right? However, whether it's possible or whether it's not possible, this is the patient's story. This is the way, this is a resource. They are trying to make meaning. They're trying to figure it out. They're trying to make meaning of their life and their situation. And so when we say, no, it likely wasn't that, we discount that effort. And so I think it doesn't mean we don't have alternative explanations, but it means we don't discount their explanations, all right? And try not to side with people, all right? So other professions, sometimes you hear, about a therapist might side with, say, oh, yeah, well, I agree with that doctor, or, oh, that therapist, I know that therapist, she's really great. Like, in other words, you should have been successful with that therapist. That's, a potential interpretation. So try not to side. Your job is to be with that person, and it's not to manage other relationships, all right? And contact parts of the story, all right? For example, they're telling you something that was terrible, you can say that must have been terribly difficult, right? Another attitude or intention is about being collaborative and negotiating, all right? Once again, we know this, we do know it, but it's about the intention and how we embody that, okay? So being open to their reports and behaviors, willingness to adjust your plan or the plan that you've developed. I had to do this a lot with Lana because she could come in very triggered by what happened during her workday and something I thought we were gonna do, we ain't gonna do. So you're working with her to figure out what you're gonna do, all right? And continually engaging their contribution. So with Lana, because she had such physical boundary challenges and challenges with touch, that's one of the reasons why her psychologist sent her to me. With touch and proximity, we worked really intimately together to figure out, if I was too close or not. And I was constantly watching for her, but also soliciting her input, right? And I did use manual treatments with her, and they were relatively successful because we worked together and we paced it properly, but through engaging her contribution. And, oh, by the way, that also helped me downregulate myself because then I wasn't as worried about hurting her, right? All right, being committed. Now, I spent a ton of time on being present and receptive because in my mind, those are the pillars, right? So I'm probably gonna just move through being committed and genuine. If you download this paper, it's open access. You can get a more in-depth description of being committed and genuine. But basically, being committed is an ethic of care that addresses the duty that clinicians have agreed upon to uphold as professionals, as well as the existential desire to be of service to another person in a way that substantively contributes to restoring some semblance of well-being in that person's life. So we have this feeling that we want to help, right? We want to help people be well. So there were two kind of strands of being committed. Being committed to understanding is not being satisfied with the generic. Okay? And by that, I mean, and I think this therapist says it really beautifully. She says, if a patient has what we would call a chip on their shoulder, you try and find out what that chip is. I see it as part of my job to get over that chip. If I can find out what brought it on, whatever, empathize, understand. So basically what she's saying is, there's some chip, she's not gonna skim over it. She wants to plumb a bit deeper to understand what's happening with that person. So that's a commitment to understanding, right? And of course, you could take that into commitment to understanding what's happening, working with the patient. Another therapist that I interviewed, he would really work with the patient to figure out exactly what was happening with their movements. And he was really committed to understanding what was triggering that person and their pain experience. So it's about not just taking things at face value sometimes, all right? Being committed to action is about making all efforts to honor the patient's best interests, all right? And honestly, it's about going the extra mile, whether it's speaking with a physician or another healthcare provider, whether it's how you manage their case and that you've gone that extra mile in speaking with claims adjusters, whether it's looking up something or talking to another colleague, right? Or even if you're working in a busy private practice, bringing in a colleague into the room with their permission, of course, and working together. It shows that you care and that you're committed. And patients, from what they told me, do recognize that, right? And they appreciate it very much. All right, that's committed. Now it's about being genuine. So really this is about being you, all right? Being honest, okay? So the definition of genuine is being real or to convey a sincerity of being in the moment in a therapeutic relationship. So it's about being honest, how you communicate, what you communicate, and how you communicate, about being yourself or congruent with who you are, all right? And investing in the personal, all right? Or going beyond the scope of the rehabilitation process or reasons they've come in. So how do you manifest being honest, all right? So the two strands of being honest were being transparent and being direct. And I have to admit, I have some baggage around this stuff because I want people to like me. And I don't want to confront people. It's challenging for me. I'm a diplomat, right? So when I worked in a WCB, sometimes you'd have to provide people information that they didn't want to hear about the system or about what their benefits were, right? But it's important to be transparent and to provide that information in a grounded way, all right? And that includes being direct, all right? So the tone and the manner that you communicate needs to be clear and forthright, all right? Not beating around the bush. And I think that that calmness is directly related to that. So when we're talking about being present, being able to take a deep breath, find that calm tone, and to be able to hold that presence while you're communicating can go a long way, all right? Now, being yourself, well, you know, I think it kind of speaks for yourself, but for example, so I'm following up Antonio Damasio today. Slightly intimidating, right? I tried a number of ways to reframe that in my mind to make it positive, okay? Now, and he's up here, and he's intellectual, and he's European, and, you know, and I'm Canadian, right? So, and so I'm literally sitting there, and I'm wondering, okay, how do I follow that up? And then I just remember what my partner always tells me, and she says, just be yourself, and you'll do really well. And that's what she says to me. And so I just reminded myself, just be yourself, all right? And so I think that's it. We think we have to be the therapist next door, or we have to be an introverted or an extrovert, or vice versa, and we don't, okay? So you really need to be congruent with yourself, all right? Investing in the personal. This is where therapists get edgy, all right? When we talk about anything that kind of moves maybe outside of why that person came to see me, okay? But patients and therapists said that this could really be important, okay? Especially with certain people. So it's about taking an interest in the person, all right? I think we all would probably agree in this room that people aren't knees, people aren't shoulders, right? And we want to be able to engage as human beings first versus patient-provider first. But having an interest in the person is about maybe going beyond that professional reason that they came in to include a personal reason, all right? So, you know, it could be talking about their family, all right? It could be acknowledging those things, right? Acknowledging hobbies, acknowledging events that they've been to that they tell you about, all right? So, and then it's about asking about them later, all right? Picking those things up and going, yeah, I'm gonna ask Lana about how her event went with her daughter, right? Because I know it's probably gonna be a happy thing for her, okay? Now, willingness to disclose. We may be okay with learning about our patients' lives. Little bit more guarded when we're talking about what we're willing to disclose about ourselves. Now, the range of, within the therapists that I worked with, the range was from, I don't tell my patients, I don't think any patients in 30 years has known how many kids I have or, you know, anything about my family. To, I've told people about my divorce when I know that they're going through a divorce, all right? So completely opposite ends of the world, right? Still professional, okay? So I think that I'm not going to read this to you. I think you get the slides. Basically, what I tried to do is I tried to create therapists, doing a mashup of all the different therapists that I interviewed and just how they talked about disclosure and the reasons for it. So, for example, Stephen, the first therapist up, he's 30 years old, he's single. His mantra is, I am who I am. With my patients, I don't change. And he's an extrovert. And so his disclosure, his ideas about disclosure are, it's not fair for patients to have to disclose while the clinician doesn't. We need to show patients we aren't white coats, right? So he talks about his family, different things they have in common, and he'll tell patients about his personal struggles, all right? And if I go to Candace on the other end, right, not that she's on the other end of the spectrum, but she's got about 10 years of clinical experience, is in a long-term common law relationship with Jane, and they have no children. She served on the disciplinary committee with her professional college, and she considers herself a very private person, right? So she's very careful about what she talks about regarding her personal life with her patients. And she'll talk about things that she thinks are not too personal, things they have in common, but she doesn't talk about family. All right? And she feels that disclosure is a slippery slope. So different attitudes about disclosure, however, and there are going to be different approaches, and all valid. And they're being congruent with themselves and who they are as people, right? I think some general things, rules to keep sort of aware of with disclosure. Disclosure shouldn't be about you, right? You shouldn't be taking up the whole space talking about your event or your weekend or whatever you did. You shouldn't be seeking therapy from your patients. So don't tell your patients your troubles, because sometimes they're like, hey, listen, like, you know, that seems pretty straightforward. But, you know, you have patients that they're mothers too. And, you know, they may be older, they may see you kind of, they may be transferring that sort of feeling of being a mother onto you, or, you know, and so sometimes it's not easy. Like, they'll start to dig a little bit, right? You know, but so you have to be very mindful of those situations, right? To stay within your professional boundaries, okay? So, in conclusion, I don't even know what time it is anymore. In conclusion, I'm hoping that one of my soapboxes, let me back up. One of my soapboxes that people, if you follow me on Twitter, you know me, is that I feel we need to operate more from principles, all right, versus just the techniques that we do or the interventions that we apply, right? And we have to bring them, we have to lift them up to a principled level so we have touchstones to operate from, okay? And so what I'm hoping are that the principles that I presented today will have you, or start to have you thinking about, am I present? Was I receptive? Am I committed? Have I demonstrated that, right? And am I being genuine, right? And I'm also hoping that we can feel better about being reflective and reflexive and self-evaluating, and start small, all right? There's a lot of information I presented today. Take one, you know, condition and one thing within one condition and go with it and experiment and see what happens, right? And lastly, relationship is reciprocal, meaning that when we're grounded, we promote our patients' groundedness. And when our patients become grounded, we promote our own safety. When we're co-regulated, all right, and in relationship, that can be a very satisfying thing. And I'm hoping that we can work more towards relationship and working relationally with the people that we work with. And that's all for right now.
All right, so we're a little short on time. So do we have any questions online? And we got one right here. All right, so I think just time for 2 questions.
I'm sorry, Rajam. Sorry.
Oh, no, you're fine.
I'm sorry.
Mike, can we get it up here a second? Well, then the people online can't hear you. Mike, no, actually, it was Karen up here.
Oh, sorry.
And hi, Karen, I haven't seen you yet. Hi.
Thank you so much for your talk. It's really in line with what I enjoy about the relationship between outcomes and trying to motivate people and the therapeutic alliances. You know, my brain just couldn't stop with the question about, do you have a self-assessment in that model that you publish? Because, I mean, after clinical training, it's very hard to create, you know, another opportunity to do self-reflection intentionally. So is there a self-assessment tool?
There's no self-assessment tool.
Next!
However, here's the deal. You're a very smart girl. What I think, what's missing from this framework is that reflective piece. And in my data, I'm going back to it. I started analyzing it, but I had to dump it. So no, there's no self-assessment tool, but I'm not a big tool person. So I am also working in tangent with a mentor of mine, and we're writing a paper on reflective practice and strategies for reflective practice. And so I've actually kind of just developed kind of I think it's a 5 or 6 step process of actually taking reflecting, but then taking it into action. All right, to structure it a little bit more.
Okay.
But very good.
half a question? I'm so sorry. I'm so sorry. I know. And it's actually about cutoff. So the idea that you become kind of connected in this therapeutic alliance, in this relationship, and you are trying to highlight resourcefulness to allow them to move on past you. But this connection sometimes is challenging to.
And here's the deal. Okay, so this is a margarita talk, right? This is, you know what I mean? Like this is like a taco talk, right? You know, by the fire. But yes, and I don't necessarily believe that you sever connections with people. Okay. I'm gonna put it out there. Everybody get nervous and twitchy, and then go have a margarita.
All right. Did we have any online questions for this speaker? No. Okay. One more in the room, Jody. Or Jason, was your hand up, or you just point? Okay. Because I skipped you last time.
Ask a question anyway.
Thank you very much. This was really helpful as far as therapeutic relationships. I'm a massage therapist, and I work in a couple different venues. One is a luxury spa, and what I notice is disclosure becomes a very slippery slope as people ask a lot of questions because they want to be trusting and comfortable, yet management is like, don't go there. Do you have a... I know
do you have? Are you trying to corner me into
Yes,
dealing with your manager or something?
It's very difficult because I like to talk and I want to make people feel comfortable.
Well, I don't know what to tell you. Like for me, to me, you need to be congruent and negotiating what you're. I think we all negotiate this though. I mean, we negotiate like our colleges, right, and what they tell us we should or shouldn't be saying to people, right, or talking about, right. So I think I don't know. I don't know what to say. I think, you know what, do what you feel is honoring you, but also just really be, because I was a talker too, right? So really mind the boundaries and then reflect it back to them to get them talking. Is that good? Okay.
Awesome. All right, thank you.
Hey, thanks.
Okay, so I have the official schedule here, so I don't mess it up again. We're going to take a short break, slightly shorter, just because there were some good questions. We're going to start back at 12:30.